So let's move on to inflammatory lesions of the wrist and hand. So we'll talk about infections, autoimmune disease, gout, and some other topics. Alrighty, well, this is a really old study. One of the first studies shows a finger with some edema within the volar soft tissues, and this was a Staph aureus cellulitis. Yeah, these are say, Tayson, what do you think of this? Again, for old studies, these are T2 weighted sequences of the distal phalanges.
Guess there is some increased signal under maybe the nail bed right there.
Okay. Yeah, and so this was a subungual infection.
Okay.
Yeah. Okay, Elior.
Okay, so we have dog bite 1 month ago. I see edema in that second digit image on the right. And then that joint, yeah, I'm not sure. I see an effusion. The bone seems to look fine.
Okay, yeah, and that this was an infected proximal interphalangeal joint from a dog bite. Alrighty, Tayson.
All right, left thumbnail dystrophy and discoloration 1 year. Rule out glomus tumor.
So what do you see here?
Some changes to the skin surrounding the nail bed, and then maybe a little lesion there in the coming out of the nail.
Okay, this is kind of what it looks like. This is the nail up here, and that's the nail bed underneath it here. And you can see some hyperemia on the ultrasound. And this was this was a Candida albicans infection of the nail bed.
Okay.
So it shows ultrasound showed a thickened plate, and then hyperemia, as we saw before, in the soft tissues in the nail bed. Okay, Elior.
Okay, we have a 53-year-old male, increasing hand pain and swelling. Right, that MCP joint, it just looks like there's bony destruction involving that joint, maybe an effusion. Right, there's more fluid extending from that joint, I think.
Okay.
Yeah, again, bony destruction. I'd be worried about infection. Yeah.
Yeah, and this turned out to be coccidimycosis. And these can be very chronic infections. They tend not to hurt as much as staph or strep or some of the more common bacterial infections, and therefore they can progress to quite an extent of bone loss before patients actually present to a doctor because of using mechanical problems and get a treatment. But obviously at this point, you already have irreversible bone damage. Okay. Tayson.
All right.
So tenderness and pain and swelling in the distal forearm.
Okay, looks like there's some soft tissue abnormality there over the first extensor compartment, right?
Yeah, right in through here. Notice if we go down to the wrist, it doesn't look too bad. This is really all pretty proximal, but this is right where you have the intersection syndrome. So I would be concerned that this could be intersection syndrome. And what do you think about the axial images?
A lot of synovial thickening there. Um,
And
maybe a partial
the
tear of that abductor.
yeah, the tendons like they're partially torn here, maybe
Yeah.
some longitudinal tears, and this was coccidimycosis.
Okay.
Jason, what kind of treatment would you use?
Guess they need some antifungals, right?
Amphotericin B.
Hmm.
Okay.
It's been around for a long time. It's very effective, though.
Okay.
Okay.
And
Leor.
Okay, we
I
have a
remember that. I remember that from med school, I think.
49-year-old male from SoCal Desert, wrist pain. We see a lot of fluid in that joint space, edema in the carpal bones. Yeah, bone erosions.
Yeah, multiple joints involved here.
Yeah. Is this another case of cocci?
It could be, but this is multiple joints. It's a little bit atypical for rheumatoid because rheumatoid usually starts out involving the uh, radial and ulnar carpal joints.
Mm-hmm.
These are really more distal than, and they kind of sparing the radiocarpal joint, which would be a little bit uncommon for psoriatic as well as rheumatoid arthritis. So you have to think about something that's atypical. Multiple bones are involved here, multiple joints are involved here. So again, you got to think about some sort of atypical infection. And when you think of atypical infection, what are the organisms you think about besides cocci in Southern California?
Some mycobacterium.
Right. And any of the mycobacteria, TB or leprosy or the kind of spectrum atypical mycobacterial disease as well. So there are a bunch of them, but they tend to be less symptomatic, more chronic type of disease where you can get a lot more destruction because they're not nearly as painful. Typically, don't get a lot of redness or even fevers with these unless they're really more systemic, which they can be, obviously. And here we can see a lot of synovial thickening here. So you certainly would have to include rheumatoid in the differential, but you have to be suspicious that it's not that because of the joints involved. And this was cocci in this particular case. Okay, Tayson.
All right. Looks like we have some fusion and synovial thickening in that PIP joint, maybe the second digit.
Right. Here are the axials. You can
It
clearly
looks like
see
it's
the
distended. Yeah.
yeah. And this was sea urchin
Wow.
synovitis. This was a diver, and this is there's some debate about whether a lot of thank you are infectious, but I think sea urchin synovitis is generally thought to be uh, a reaction to the toxins. But
They're extremely painful.
yeah, uh, but you always have to be worried about infection with these as well.
Okay.
Okay, Elior.
17-year-old right wrist pain for 3 weeks. The distal ulna is jumping out at me. There's some lucency there.
Right.
Not sure what that could be. Huh. And on the MR, we see some maybe a sinus tract and some maybe a small fluid, intraosseous fluid collection there.
Okay.
Might be, yeah, and some fluid around the soft tissues, in the surrounding soft tissues. I'd be worried about an infection.
Okay.
Brodie abscess, okay.
And here's what it looks like on the rest of the MRs.
Right. Fluid collection with some ring enhancement. Yeah.
Yeah. Okay, here's a new case, Tayson.
All right. Looks like at the distal metaphysis, we have a eye signal that extends through the growth plate there. Um,
Yeah, with a lot of
Could
surrounding
be
soft tissue.
osteomyelitis. All right.
Okay. Here's what the T1 looks like,
Yeah, diffusely edematous there.
breaking through the cortex into the soft tissues.
Yeah, we have a break of the cortex there in the
And then
dorsal affect there.
we can see some hypertrophic bone formation here, maybe part of an involucrum. And then here we can see the soft tissue extending all the way around both bones.
Yeah. Yeah, definitely.
Okay, so that was then. Now 10 months later, this is what it looks like.
All right, so decreased edema in that metaphysis, but there's still a sinus tract and a cortical defect there.
Now, maybe
Uh,
a little extension distally here to the growth plate.
yeah, and that like that growth plate looks very irregular there.
But it looks well defined and well contained at this point without the diffuse edema. And here we can see the bone
Still some
scan.
uptake on the bone scan. Okay, involucrum.
Yeah, now, do you know what an involucrum is?
It's the stage before a sequestrum.
Well, let's see. What the involucrum is actually new bone formation. That this isn't the best example of it. It's new bone formation on the outside of dead infected bone, and it's kind of the body's response to try to contain the infection into the bone without systemic spread. And it can be very thickened, irregular bone, and can cause widening of the bone in that location. If you then have some of the central bone that's dead break off and swim around in a abscess within the bone, what's that called?
Um, Sequestrum, right?
Right. Good. Okay. And then the drainage, the sinus tract, technically, when it's infected, is called a cloaca.
Okay.
Elior.
Okay, looking at that DIP joint, there's destruction of that bone, there's surrounding edema, there's bone edema. Okay.
So that
And
was
these have to
staph
open
osteomyelitis.
and these have to open and the nail bed and reverse it, fold it forward, and then use antibiotics, of course. And on here you put non-sticky bandage in that area so that the nail doesn't attach to it, and something non-sticky. I forgot the name of the material, but anyway, until you're healed, you can't put the nail back. Once you got rid of the infection, then you put the nail back in place. usually get out pretty good results, but some of these can become a real problem.
Thank you, John.
It just keeps on progressing if you have a very low resistance.
Okay.
And that can become a patient of yours for 10 years, 20 years. Just keep cutting away.
That's bad. Tayson.
All right, second digit. Is there an amputation there?
I
Or
don't
is this
think
just
so. I think just a lot of edema within the bone here.
okay, yeah.
Soft tissue.
Edema in the soft tissue in the adjacent bone.
Yeah, the axials.
Yeah, it looks like the cortex is very irregular in that volar aspect.
Yeah. Yeah, that was osteomyelitis.
That catalog shot, is that what you got?
That's what she got. Yeah.
She won't forget that.
Elior.
70-year-old, left arm swelling and pain. Past history of hypertension and diabetes. I see a lot of subcutaneous soft tissue edema, pretty circumferential, mostly on the dorsal. A lot of edema there dorsally. Yeah, going in between the muscle, like traveling along the muscle fascia. Here we see fluid collections within the muscle, or
This could be fluid
between the
collections or it
muscles.
could be necrosis of the muscle.
I would bet on pus.
Path report chronic active inflammation, gangrenous change, epidermal necrosis.
Yeah, and so this was necrotizing fasciitis.
Hmm.
Yeah, and very difficult problem.
It's miserable to deal with.
Yeah.
But if you're going to do surgery, you better do it as far proximal as you can get away with.
Tayson.
In terms of amputation.
All right. So we're looking at the flexor compartment here. It looks like a lot of synovial thickening and fluid and a bunch of debris inside the flexor tendon.
So what's kind of your thought here?
Some sort of inflammatory arthropathy with some
Okay. And then
rice
it looks like you've
bodies.
got little rice bodies here, or something similar to rice bodies. So a number of things to think about. You can think about rheumatoid arthritis, but we're talking about infections here. And this is not very typical of rheumatoid arthritis. So let's think about infections. What kind of infections might you think about?
Guess some sort of fungal infection.
Well,
Aerobic or anaerobic?
yeah, if it were staph or strep, the patient would probably be very, very sick at this point. It looks like it's been here for a while. It takes a while to develop these synovial thickenings, kind of called rice bodies. And this was an atypical mycobacterial disease with tenosynovitis involving the flexor tendons.
Okay.
Elior?
Okay, so here we see thickening or tenosynovitis of the flexor tendons with marked synovial thickening, and particularly that extending to that second digit.
Right. This is extensive flexor tenosynovitis, and this also is atypical mycobacterial disease.
Tayson, how would you work that up?
Refer to an infectious disease. Maybe get some sampling.
Well, yeah, I think the first thing I would do is do the usual blood test stuff and then PPD to see if you get a reaction, and then and from there you go with treatment.
Yeah. And I think this
Don't
is,
forget the PPD business because that's very helpful,
Mm-hmm.
yeah, and these kinds of
and
things,
always get a chest X-ray.
yeah, especially in this day and age, because TB is on a big upswing right now, especially in
And
California. So,
it's becoming very, very popular. It's going to get um, much more so.
yeah.
Have,
So this was another atypical mycobacterial tenosynovitis. Okay. I think, Tayson, this is yours.
Yeah. So still looks like we're in the flexor
Okay.
tendon region where I see a lot of, yeah, again, synovial distension and debris.
Right. And similar to the previous
Yeah.
one, you see all this synovial thickening and fluid extending along the flexor tendons.
Yeah, again, probably some sort of atypical.
Yeah, this is Mycobacteria avium. Okay, Elior.
So we see a lot of edema in the carpal bones. Um, I think, yeah, the joint effusion with synovial thickening. Again, yes, debris in this synovial fluid.
Yeah, multiple joints involved.
Another atypical infection.
Could be atypical, could be typical. This one's typical. So this was TB.
Okay.
Again, you can get a lot of, with these kind of diseases. One is, these are all cases we've seen here in Southern California. They're not, they're not, they're not common, but they're not really rare. And with TB, it's typically more common, or there's a higher incidence than there is with the atypical generally. And you can often get a lot of multi-level bone involvement, and it's classic of the spine where you can have 5 or 6 or 7 levels all involved with TB, with large what are called cold abscesses. When we do the spine, we'll see some of those because, again, it can be an indolent infection that can last for years with relatively minimal symptoms. So they're not picked up early like a staph or a strep or salmonella or some of the others. So when you see a lot of involvement of multiple bones, a lot of synovial thickening in someone who's not, in the hospital, then you've got to think about these atypical mycobacterial diseases and the fungal diseases. Tayson?
we used to have special hospitals for tuberculosis, and the nurses used to get BCG injections as vaccines that they weren't worth anything, but
Yeah.
they nevertheless gave it to them. And that turned the patient into PPD positive. That happened to my wife.
Yeah. Okay. So go ahead.
70-year-old female, mass with slight pain around the right wrist for 2 years, no fever. Masses are soft on exam and no specific lab findings.
Here's an X-ray.
I don't see the ulnar styloid too well. I don't know if the margin of the distal ulna is a little bit scalloped as well. So a lot of fluid and synovial thickening there.
These are T1 weighted images. Here are the fluid sensitive images. See a lot of kind of fluid, kind of with dirty fluid in it, and a lot of
It
synovial.
looks like an abscess.
Yeah, see.
Yeah, but I guess abscess, 2 years kind of doesn't fit that picture.
So what are you thinking about? Well, actually, let's say it is an abscess and it's been around for 2 years.
It had to
What
be
are you thinking about?
tuberculosis or something.
Yeah. So yeah, this would be a large cold abscess.
Yeah.
And there you can see the peripheral enhancement, typical of abscesses, in someone who's not as sick as you would expect someone with a typical bacterial infection, and this was TB.
Okay.
Okay, Elior.
So a 50-year-old with oligoarthropathy. See a lot of bone erosions at the distal radial ulnar joint, various places in the wrist, also in the shoulder. Yeah, I would think about, okay, the MR synovial fluid with these little rice bodies.
Yeah.
Think about TB. Yeah, lots of rice bodies in the glenohumeral joint.
And these huge abscesses, big erosions in the bones, multiple joints are involved.
Mm-hmm.
This is TB. Okay, Tayson.
All right, 37-year-old male ulnar-sided wrist pain. So there's a lucency over the distal ulnar styloid. Looks like a lot of destructive change to the distal ulna and synovial thickening and soft tissue thickening extending into the subacute tissues.
Yeah. This is from Brazil.
Yeah, I mean, I guess again an infectious process. TB.
Yeah, this turned out to be a fungal infection with granuloma. I don't know which fungus, but this was a fungal infection. Okay. Well, why don't we move on to rheumatoid arthritis? So this is what end-stage rheumatoid arthritis used to look like back with marked bony destruction. And obviously these hands are not functional. So it's something we want to make sure we now with effective treatment treat much earlier than this before you have all these irreversible changes. And just remember that bone destruction is the primary source of disability in rheumatoid arthritis. So we want to pick up any sort of osteitis or bone destruction early in the course of the disease so it can be stopped before you have functional loss. Now, I don't, have we talked about the kind of different stages of rheumatoid arthritis, or is this the first time this year?
Yeah, we have previously.
Yeah, I thought we did. So the pathogenesis that you start out with synovial inflammation. I think it's still unclear exactly what produces this. Then you can get infiltration of the inflammatory disease into the bone. And now we know that it's primarily at the capsular insertion, probably because the inflammation probably starts in the synovium. The synovial inflammation either allows active biochemical molecules to diffuse into the bone at the synovial insertion, which then attracts inflammatory cells from the vascular system into the bone next to the capsular attachment, or there's a direct infiltration of inflammatory cells from the synovium through the cortex of the bone into the adjacent bone. And then you get replacement of the typical marrow fat by inflammatory cells, which is a true osteitis. This osteitis destroys the trabecular bone next to the capsular insertion, and this can extend to the joint margin, which then you start getting subchondral bone loss, which leads to articular cartilage destruction, and then finally joint destruction. Now, if you look at these different stages, there are different imaging tools to be helpful. So in the synovial inflammatory stage, you can see contrast MRI can pick up the early synovial inflammation, especially if you use a dynamic MR study looking at contrast enhancement within the first minute of the injection. That's very specific for active inflammatory disease. I think we'll talk more about that in a minute. Or ultrasound, where you can pick up a lot of neovascularity in these particular areas. Then this can infiltrate into the bone. Once it gets in the bone, ultrasound and x-rays in the early stages are not very sensitive. MR is really useful at looking at the osteitis phase of the early inflammatory stage before you get bone destruction. Once you get destruction of bone, then you can see the erosions by both MR or CT. Once you have bone destruction that can be seen by CT, that's generally irreversible changes. So if you wait till it's CT positive, you've really waited too late to reverse the process because you already have just irreversible changes. And then as you get more destructions, you can see CT is really the best for looking at cortical destruction, followed by MR, followed by ultrasound, followed by X-ray. Then you can get destruction of the subchondral bone, which you can only see really well by MR, until it's a much later stage where CT can see the trabecular destruction, and then articular cartilage and joint destruction is best evaluated by MR. Generally, you'd like to have spatial resolution in the hand and wrist, and one sequence which is sensitive for the bone fat interface with isotropic spatial resolution of less than a millimeter. We used to get this by 3D gradient echo images at lower field. At higher field, as we've discussed, that's lots not so good because of the at higher field, we have a lot of signal loss due to susceptibility artifact that we don't have at low field. In higher fields, we try to get thinner cuts. And then if we're looking for early erosions and early synovitis, sometimes contrast can be helpful to pick up the neovascularity of the inflammatory process. So here's a case where we have a 1.5 Tesla imaging, and we can see some irregularity of the bones here, but this is the normal. That's a little bit irregular. That's a little abnormal. This is a small erosion. That's normal, normal, and normal. And then in the old days with gradient echo, we could occasionally pick up some erosive changes in the bone. Here we can see that erosion. In this case, the gradient echoes are 1 millimeter isotropic images, and here's a T1 weighted image showing you can see much better kind of contrast when it's a large lesion with non-gradient echo images. So, and then
on X-ray, John, on X-ray, you probably wouldn't see that, would you?
Yeah, this would be too small typically to see by X-ray unless you're really lucky getting just the right angle, but generally not. And the PD fat tend to not be great contrast for these early lesions either. And then here we can see here's a 3 millimeter thick cut. Here are the 1 millimeter thick cuts in a 3 millimeter gradient echo. Using different techniques. These are showing the erosive changes which you can get in rheumatoid arthritis. There's a lot of synovial thickening and multiple erosions. We really like to pick it up long before you get to this degree of bone destruction.
Well, it's like cancer. The sooner you pick it up, the better you are.
Right. And here we can see the erosive changes on the axial images. prominent erosive changes within the bone. Okay. So with MR, we really look for soft tissue changes, which tend to be nonspecific, thickening of the synovium, edema within the synovium, and enhancement. And again, generally the most sensitive and specific finding in very early disease is dynamic enhancement. Basically, you put in the bolus and you scan within 1 minute. And if you see enhancement, that's typically associated with histology showing neovascularity, and it's highly aggressive, active, inflammatory disease. Then it takes time for the bone changes to occur. You get erosive changes. And we've talked a little bit about how these occur. I'm going to talk a little bit more, I think, in a minute. Generally, in the area of the end of the bones in the hand, typically you start getting inflammatory disease in the subcortical bone at the where the capsule attaches, typically on the medial and lateral aspect of the metacarpal heads. It tends to be earliest detected in areas where you have the largest amount of stress on the cortex. Maybe that more likely to have interruption of the subchondral bone, allowing either biochemically active molecules or actually inflammatory cells to then extend from the synovium into the subchondral bone, where it produces inflammatory change, which then dissolves the trabecular bone, giving the subchondral geodes or subcortical geodes in those locations, and then the overlying cortex breaks down and you get the erosive changes. And then you get soft tissue edema. Later on, when you get destruction of the articular cartilage, you get joint space narrowing, but this is really late disease, long after you have irreversible changes and then bone destruction and deformity. So the next thing that happens then is you get cortical destruction. As we're talking about, this is an old study from 2007 by McGonigal et al. In England, where at this time, as I was taught in medical school, the erosions were thought to change in the bare area between the articular cartilage and the attachment of the capsule. And the next study that they published, they actually found that that was wrong, and that the erosions really start here at the capsular insertion, not in the bare area where we were taught before. And once you get the actual destruction of the cortical bone, then MR and CT are similar in sensitivity, but if you're and that's irreversible change, if you pick it up earlier than this, the MR is going to be positive and the CT is going to be negative. In many studies, this is a number of years ago, there were many studies in the peer-reviewed literature at that time that shows that MR was far more sensitive than radiographs at detecting these early erosive changes. And then in 2009, McGonigal et al. Came out with a paper showing that these erosions really occur at the capsular insertion. Here's just an ultrasound from Australia, which shows erosions that you can see by ultrasound, but generally we much prefer to use MR scans. Okay. And very early on, you can actually see these changes better with contrast than with non-contrast studies. So in the ULAR, which is European League Against Rheumatism, and a lot of their studies that were published a few years ago, and their recommendations was that you could use an abbreviated MR technique, which had only 3 sequences, one of which was a post-contrast T1-weighted fat suppressed sequence, and that they thought was the most sensitive for detecting erosive changes because they tend to enhance avidly by contrast. In the U.S., we tend not to be as aggressive with contrast. Here's just from a study that we published in 2003 where I did dynamic contrast enhancement. Here's a T1 weighted image on a 1 Tesla extremity scanner, and at 12 seconds, we can see there's some synovial thickening here involving the second, third metacarpal phalangeal joints, but the signal intensity looks normal. At 24 seconds, we start to pick up contrast enhancement in the area where you have the synovial changes. At 36 seconds, it became much more prominent here, and then and that's this is the typical finding that you can see in early aggressive inflammatory disease. And then histologically, you have neovascularity here, which goes along with active inflammatory changes. Here we can see a marker over where the patient was symptomatic. We can see some thickening of the synovium around the metacarpal head. In this particular case, this patient had a sagittal band tear. We've already talked about sagittal bands, and it's a fairly common injury in chronic rheumatoid arthritis where the inflammatory disease starts affecting the sagittal band, leading to weakening and tearing of the sagittal band. We've talked about the chronic deformities. One of the classic one in rheumatoid arthritis is actually the boutonniere deformity, where you get flexion of the proximal, extension of the distal phalangeal joints, and those are typically associated with tears of the pulley system, which we talked about in previous lectures. And when that occurs, you can see that the tendons, instead of being over the top, drape over to the side, which means they pull from the wrong direction, which leads to this chronic flexion deformity of the proximal interphalangeal joint. And here's a gradient echo image and a low-field scanner showing severe destructive changes of the metacarpal head. And this is one of the typical ones known in the early days for rheumatoid arthritis, long-standing disease called a pencil and cup deformity, where you get erosive changes on either side of the metacarpal head. And this is the pencil, the sharp point of the pencil, where there's a little bit of subchondral bone still left before it gets destroyed. And then the cup would be the articular surface of the proximal phalanx. Another common abnormality that you see in rheumatoid arthritis, which is pretty specific for rheumatoid arthritis, is volar subluxation of the base of the proximal phalanges, and then the tendons pull them proximally, and they get these very characteristic deformities of the metacarpal phalangeal joints. And I've only seen this in rheumatoid arthritis. I'm sure it can occur with other diseases, but it's been pretty pathognomonic of rheumatoid arthritis in my experience when we used to do a lot of imaging of RA patients.
It also is ulnar drift, right?
Yeah, good. And then this is just another example. Here's the metacarpal bone. Here's the proximal phalanx. It's volarly displaced and proximally retracted, and you get a typical deformity of the distal end of the metacarpal, where you get a erosive change from just the mechanical banging of the displaced proximal phalanx here against the distal metacarpal. Okay. Now, this can also occur more proximally. Here is the wrist, where we have destruction of the radial ulnar carpal joint space. And here you can see volar subluxation of the whole carpal bones with proximal migration and long-standing rheumatoid arthritis. Another deformity which leads to very poor function of the wrist, as you can imagine.
Was that patient proximal root carpectomy?
Yeah, I don't think this one has had a carpectomy yet. Here's the lunate.
It doesn't look like much left.
Yeah.
After you remove the proximal row, and the next thing is fusion to the middle finger with a plate, and that usually is pretty stable.
Okay. And here is just a case where we can see on the axial images, the carpal bones volar to the radius and the ulna due to the deformity. Okay, well, let's see here. Tayson, what do you think of this case?
All right, looks like we have very severe tenosynovitis of all the flexor tendons.
Right. And so you could think about atypical mycobacterial or cocci or something like that, but this was a patient with rheumatoid arthritis. And this is typical tenosynovitis of rheumatoid arthritis, and it's much more commonly seen in infectious diseases. Okay, Elior.
Okay, so here, radiographs of the wrist, we see erosive change in the bones, multiple joints.
Yeah.
Mm-hmm.
And there's the MR.
All right, again, multiple bone erosions, edema in the bone, osteitis.
Yeah. Many more erosions on the MR. And here we can see marked synovial thickening, marked irregularity due to extensive erosive changes of the carpal bones. And again, rheumatoid arthritis. Tayson.
All right, we have a lot of synovial thickening in that extensor carpi ulnaris tendon there. Maybe some erosive changes to that ulnar styloid.
Okay. Yeah, and this was rheumatoid arthritis. Okay, Elior.
Yeah, we see a lot of synovial thickening within the tendon sheaths.
Right, both dorsal, both extensor and flexor areas here, and around the actual carpal joint spaces as well.
Mm-hmm.
And so this was rheumatoid arthritis. Okay, and then here again we can see flexor tendons, marked synovial thickening here throughout the flexor tendon sheaths. Maybe some osteitis, the first metacarpal over here. Okay, Tayson, what do you think of this case? Another patient with known rheumatoid arthritis.
All right, there's definitely erosion and remodeling of the distal ulna and the ulnar aspect of the radius. A lot of surrounding synovial thickening.
So what do we call this?
Ulnar impaction.
Well, this would be ulnar impingement.
Impingement,
Ulnar
sorry.
impaction would be against the lunate. Ulnar impingement is where you have a shortened radius, shortened ulna, either from rheumatoid arthritis, erosive changes from rheumatoid arthritis, or post-surgical, and then the distal ulna impinges upon the ulnar aspect of the distal radius, producing this erosive change, which you see here. Here we can see
the
marked
panels
synovial
is
thickening.
doing the impinging.
Yeah, and here's the big pannus, all this synovial thickening. Good.
Okay.
Okay.
One of the things about the wrist of the hand, there are no real great replacements for the wrist. The tests have been done up to 5 years, and some have worked pretty well. But after that, things go south.
Okay.
So we don't really have a good wrist replacement. It is suggested the best thing to do is fusion. You don't want to go through a wrist replacement and then have a fusion afterwards. That's a lot of surgery.
Thanks, John. Elior, what do you think of this case?
Okay, so on this radiograph question of erosions, Mm, I don't I don't see anything
Yeah,
that I would call erosions, but
maybe there, maybe here. Nothing
okay.
to say there. Here's the MR exam. This is a low field gradient echo MR examination. And here,
Okay.
this area here is actually this area there. You can
Okay.
clearly, much more clearly see the actual erosive change there. And this is a stir image for very poor quality, less well visualized. We have better contrast for these chronic erosive changes with the gradient echo sequences. And here's a T1 wave sequence.
I'm thinking what lawyers would say after they take the X-ray, which is pretty normal, and then they the MRI, which
Yeah.
is abnormal. They'll say the MRI caused it.
Okay.
It's known as post hoc ergo propter hoc. After this, therefore, because of this.
Now, what they really say is, oh, the MR can see it much better. We'll make sure we get MR on all of our clients so that we can maximize the amount of pathology we pick up for the settlement. Okay, Tayson, here are some cone down X-rays on a patient with rheumatoid arthritis and pain.
Maybe erosions at the metacarpal heads. I mean, without any context, I probably wouldn't have said anything about it.
Okay, so then for a while we used a very low field, this was a tabletop device that used a non-uniform magnetic field. Yeah, it was 0.2 Tesla, but non-uniform field, which means you have to do 3D imaging, everything. And here we can clearly see that there is an erosion here, an erosion there, that are much more difficult to pick up on the X-rays, which
Yeah.
goes along with ours and other people's studies showing that MR was far more sensitive for erosive changes.
Would a CT scan pick any of that up, John?
CT would pick these up, yes. If it's just osteitis, then CT won't. But for erosions like this, a CT would pick it up. Yeah. So well, we can end with this. This was this study that we published in the Journal of Rheumatology back in 2004. We looked at 132 patients that we got MR scans on. We found that we had 125 erosions by MR, 78 erosions by X-rays. So in this particular study, MR was showed many more lesions, and these were all patients who clinically had rheumatoid arthritis. See, why don't we stop here and we'll pick up here tomorrow and move on through rheumatoid arthritis. Okay?
All right. Thank you.
Thanks.
Have a good evening, everybody.
Thank you. You too.
You too.